So budaya kat Malaysia ni, buat doktor buatlah yang terbaik. Kalau saya ada kereta Alza saya 16 tahun, saya bawa ke mekanik, saya kata, mekanik buatlah yang terbaik. Mekanik kata, hantar pergi hantar pergi lupuskan je lah, dah 16 tahun dah Alza kau ni. Tak sesuai lah kita nak kata macam tu kat orang. So the wording buatlah yang terbaik tu, sebab people thought that doctors knows best. We do know a lot. We probably don't know best because we don't know you.
Okay, Assalamualaikum. Selamat datang Dr Ammar. Dr Ammar. So dalam podcast hari ni, mungkin kita tak tahu kot, ramai orang tak tahu apa tu Dr Pakar Paliatif. Selalu kita dengar doktor kanser kan. So tapi Dr Ammar ni adalah Dr Pakar Perubatan dan dia sambung belajar lagi, dia sambung dalam palliative care. So palliative care ni kita boleh kata sebahagian daripada rawatan daripada pesakit-pesakit yang mempunyai penyakit kanser ni lah. Tapi sebelum kita go through dengan Dr Ammar ni, saya nak share sikit lah statistik dekat Malaysia ni. Kita tengok cases of cancer dekat Malaysia ni, kita tengok makin meningkat lah. Kalau tengok 2020 Dr Ammar, lebih kurang 48,000 48,000 new cases of cancer didiagnose. Dan based on statistik, they expected by 2040 the number is expected to double. So mungkin by 2040 case kita dekat 100,000 setahun. So mungkin Dr Ammar boleh introduce yourself sikit dan cerita sikit palliative care ni, apa skop dia, apa beza dia dengan doktor kanser ataupun onkologi ni.
Assalamualaikum warahmatullahi wabarakatuh. Nama saya Ammar. Saya selalu introduce diri saya sebagai bapa anak 7. Itu saya selalu introduce saya lah. So mainly a family man, tapi yalah kita belajar bidang kita ni. Betul, Sani kata cancer is actually on the rise. One of the reason kenapa cancer is on the rise is actually because we are looking for it better, we are diagnosing it better, and people are more aware, people coming forward with symptom better. So that's why the expected number tu akan rise, but we are detecting more. And there is a lot of treatment for cancer, which is good. Cumanya bidang saya ni bukan bidang cancer, tapi bidang saya ni banyak handle pesakit cancer. So jadinya onkologi, bahagian cancer, onkologi itself, itu bidang wife saya. Dia menguruskan solid organ cancer. So solid organ ni maksudnya any cancer yang bukan darah. So there's another bidang, nama dia hematology, bidang bahagian darah lah, hematology. So dia yang handlekan blood related cancer, termasuk lymphoma, leukemia, apa semua tu. So other than that, solid organ dia akan masuk bawah onkologi. So agak luas juga bidang tu. People are getting better at diagnosing colon cancer, lung cancer, breast cancer, and they're doing quite good lah. Treatment, everything is actually doing quite good. But nature of cancer itself, over time, bila orang kena cancer ni, dia ada dua komponen yang penting, iaitu komponen genetik dan komponen environment. So you may be exposed with a lot of environmental factor tapi tak pernah kena cancer. Kita dengar kan, orang pakcik tu merokok sampai umur 70 tak ada kanser pun. So maybe environmental factor dia besar tetapi genetic komponen dia tak ada. So dia terlindung in that sense. Dan kita ni berketurunan, kita lahirkan daripada keturunan asal awal-awal ke bawah. So studies have shown memang our genetic make-up is not the same as it was 500, 1,000 years ago. There's a lot of degradation, there's a lot of repeat genome dah yang menyebabkan kita mudah untuk mendapatkan kanser keturunan terkemudian ni lah. So environmental factor plus genetic factor memang akan menyebabkan orang tu prone dapat kanser. That's why it's becoming more rampant sekarang. Betul. So with cancer, even though you got treat early, everything semua tu, so genetically you might have it. So eventually down the line, apa yang kita risau adalah recurrence of the cancer. Then cancer tu datang balik. Dan semua pesakit kanser akan tahu hakikat ni. Even rawatan untuk kanser pun, some countries where they are quite advanced, dia rawat awal dan patient with cancer survive long, 20-30 years down the line, they are getting cancers because of the treatment. And ini tak dapat dinafikan lah. Rawatan cancer to itself may cause cancer down the line. So macam kalau you umur 60, you dapat rawatan cancer, you may get another cancer when you're 100. which is probably not that important lah. But if you're in your 20s, you dapat rawatan untuk kanser, and then you're in your 40s, you're probably going to treat secondary cancer lah. And with that treatment pun, another 20 years, 60, 70, tertiary cancer. That is what's happening in the Western world nowadays lah, because they're picking up more cancer, they're treating more aggressively. So complication of the treatment tu lebih nyata lah, macam rawatan ubat darah tinggi, rawatan kecil manis kan ada komplikasi dia, sama je lah rawatan kanser pun ada jugalah. Palliative care, WHO ada definition dia, basically it's a whole person care where the aim of palliative care has nothing to do with cancer actually. It's an alleviation of suffering for patient and their families within resources lah, with whatever resource yang ada lah. So palliative care ni dia ada, generally we practice 4 domain dia, 4 bahagian manusia ni kita cuba uruskan. There's a physical domain which is sakit, lelah, mengah, apa semua tu. There's a psychosocial domain yang pesakit, kalau dia cikgu, dia nak kerja balik cikgu, atau dia doktor nak kerja balik doktor, dan tapi dengan penyakit dia tu macam mana nak kita uruskan. There's the emotional domain. Emotion yang kita manusia memang kita ada emotion, ada marah lah, penyakit, marah lah, resah lah, frust lah, sedih lah. So the emotion domain we try to help juga. And there's a spiritual domain. So kita kat negara Malaysia ni, a lot of people believe that spiritual domain is pasal agama. Actually it's not. Religiosity is part of spirituality. Ada orang dia tak ada agama tapi dia masih ada spirituality. Dalam Islam, kepercayaan kepada ketuhanan lah, there is a bigger force. There's a bigger force in the world. Walaupun they don't believe in God, they believe there is a bigger force. Okay, so this is the 4 domains that palliative care do, and what we do is actually we alleviate suffering by going through all these 4 domains for the patient and family. Itu yang pasal palliative care. So palliative care banyak disangkutkan dengan onkologi, dengan kanser. Yes, betul. A lot of our patient ada kanser, eventually bila masuk ke stage 4 ni, okay, orang kata rujuk ke palliative care lah. Okay, but what we try to do actually, kita masa dapat tahu tu itself, tak kira stage 1 ke stage tak unstageable ke, ada orang saya tak nak siasat, saya tak tahu saya stage apa, saya tahu mungkin ada kanser, saya tak nak siasat. We also take those kind of people because what we do is elevation of suffering. So contohnya, ada makcik umur 65, anak 3, anak dah besar jadi pensyarah semua. Tapi makcik ni dia dah hidup dengan suami dia I don't know 40-50 years, dan suami dia baru meninggal 6 bulan lepas. Okay, so bila tengok ada lump dekat breast dia, dia kata that's it. Dia pun makcik ni maybe kerja cikgu ke, kerja engineer ke, dia educated person. They found a lump in the breast and she said no, saya tak nak siasat. Okay, so doktor akan, biasalah doktor bedah, doktor bayan, biasa dia tak ada form lagi ada, doktor bedah semua akan push, makcik kena buat, kena siasat. I don't want. So anak dia semua successful, mak kena. So makcik ni stress. Makcik ni stress lah. Anak dia marah kat dia, doktor marah kat dia, kena siasat pun ni, kena boleh buat something. Breast cancer is actually quite manageable lah kan. Tapi she lost her husband 6 months ago. So kalau orang duk push kena siasat, yelah makcik tu dah lagi stres, dia lagi tak nak dengarnya, dia mengamuk lah, buat macam-macam agam lah. So if the service general surgery tu contohnya dapat refer ke palliative care, what we do is actually we sit down and talk to her. We try to assess from the 4 quadrant tu, the physical, psychosocial, emotional and the spiritual, what is causing her distress. So in her case, maybe she's having emotional distress, lost her husband 6 months ago. Maybe she's having psychosocial distress, anak semua successful, she's living alone, and husband partner dia 6 months ago dah tak ada. We try to alleviate that problem. Spiritual, maybe dia tengah menyalahkan Tuhan, kenapa ambil suami dia awal, padahal suami dia sihat je, maybe something like that. And maybe she has pain from the breast ke apa ke, from whatever back pain ke apa ke, yang tak di-address lagi, menyebabkan dia tak nak fikir dengan elok. So we try to assess the person and then alleviate apa-apa kita boleh. Then sometimes bila kita borak-borak elok macam tu, okay, sebenarnya saya tengah sedih dengan suami saya, bagilah saya masa 2-3 bulan nak cerita tentang sedihnya. Anak-anak saya ni saya cerita pasal ayah dia meninggal ni, dia orang duk berebut harta ni apa semua, you know. All this can come up. We try to help with this, and then eventually patient tu, okay, sebenarnya saya nak rawat, saya tahu ni mungkin kanser, saya nak rawat tapi serabut dengan benda lain. So if this kind of person initially was referred to palliative care, we got to alleviate what is causing her suffering, and then she now agrees for treatment, go ahead, buat investigation, buat siasatan. Kalau sesuai buat pembedahan apa semua tu, we will support her along the way, and if she's no longer have a life-limiting illness, then we discharge her. So that's what palliative care do. Tapi secara realitinya, what we normally get is stage 4 cancer, tak boleh buat apa-apa dah, refer palliative care. Kalau yang pesakit okay lagi, we usually the journey with the patient for 6 months, a few years sometimes, but usually generally when people refer to palliative care, they have 6 months to 1 year prognosis estimated, and then they refer to palliative care, and we try to manage them lah, uruskan pesakit ni. Yang kita orang agak sedih ni lah, banyaknya daripada pakar perubatan, daripada pembedahan, nazak baru rujuk, so kita orang tempat 2-3 hari je jumpa, kurangkan sakit sikit dengan ubat kita orang, end of story. So what we do also as well afterwards, because pesakit mungkin dah meninggal, so what you do actually bereavement lah, tapi bereavement I have to admit lah, it's not that well done at the moment in Malaysia. We look after, like I said, palliative care, we alleviate suffering for the patient and family. So after patient pass away, the bereavement of the family, we also took into context juga lah. We call up that, how you doing, how you handling, because there's such a thing as a complicated grieving, which can cause effect to the person health lah. So that's what palliative care is. So dia tak semestinya kanser sahaja, dia boleh penyakit jantung, penyakit buah pinggang dah banyak dah sekarang ni yang decided not to go for dialysis, everything semua. So we take those patient in. That is generally what palliative care do lah. We don't deal with death sahaja, we deal with managing a person if they have a life-limiting illness, penyakit yang tak boleh sembuh, and the prognosis usually 6 months to 1 year. We tend to handle that. But if for some reason their disease boleh di-cure, boleh investigate, it's okay, we can go through them along the journey and we discharge them. That's generally about palliative care.
Tapi I think that is quite a misconception regarding palliative care lah. Even I think most doctors pun think that, like what you said just now, bila end of care, meaning like we got nothing else to help the patient with, okay, refer palliative care, you take over from there kan, dah tak ada benda nak buat dah kan, so you take over lah. But I think this is a really good, kita kata eye-opening lah, bila Dr. Ammar cakap actually palliative care pun not necessarily for terminal ill patients only, but even those with end stage kidney failures and even heart attacks. Palliative care, I think what we understand as an outsider yang bukan dalam department you is when we refer to palliative care is more lebih kepada untuk kurangkan sakit patient, systemic punya pain kan. I think that is what generally, if you ask anyone what does palliative care do, inside palliative care itself there is something called, kita panggil advanced care planning, ACP. Maybe doktor boleh sentuh sikit on ACP and also who is involved kan. ACP ni melibatkan siapa, and generally what is ACP lah. I think most of us pun tak pernah dengar lah regarding ACP dalam palliative care ni.
Okay, saya cerita sikit. So ACP was coined, I think, about in the 1960s in America initially. If I'm not mistaken, I might be wrong. But when they found out not everybody boleh dirawat sama. Okay, so manusia bukan robot. So jadinya not everybody can be treated the same. So what they found out, actually people's value differ, then people perception of treatment differ. So things evolve and everything, so that's why American certain states, their ACP is a legally binding document. So kalau you dah buat ACP, doctor, nurse, the healthcare professional have to follow that instruction because it's legally binding. Singapore made it legally binding, tapi being an Asian country, they found that there is a bit of a problem with it. Malaysia is not legally binding, tak ada dalam perundangan kita lagi, but we are going to roll out an ACP program I think either this year or next year, nationwide. So what advanced care planning is actually not about palliative care saja. It's actually about you as a person. So apa kita nak is actually kita nak a person makes a decision about his or her health. So budaya kat Malaysia ni, doktor buatlah yang terbaik. Kalau saya ada kereta Alsa saya 16 tahun, saya bawa ke mekanik, saya kata, mekanik buatlah yang terbaik. Mekanik kata, hantar pergi lupuskan je lah, dah 16 tahun dah Alsa kau ni. Tak sesuai lah kita nak kata je dekat orang. So the wording buatlah yang terbaik tu, sebab people thought that doctors knows best. We do know a lot. We probably don't know best because we don't know you. Okay, so advanced care planning is to understand for the healthcare worker to understand your value. Contohnya saya bagi contoh, kalau seorang macam tadi saya bagi contoh seorang makcik anak 3 orang, suami meninggal. So kalau makcik tu, okay, she got breast cancer, she wanted to be treated but she's just frustrated dengan what's going on with her life at the moment. Okay, if we had known that value for her, she wants to be treated, then we would go ahead and treat that. So kalau if she had a conversation, so ACP should be done with a professional healthcare juga, you be trained to do ACP juga lah. So if she had a conversation, the children knows that this woman want to be treated, tapi for some reason dia resistant at this point, yang sebelum meninggal 6 bulan kan. So we understand her value is to get treatment, tapi kenapa dia resistant ni? So there is a problem. So kena identify apa problem tu. So contoh another example lagi. So contohnya seorang pakcik umur 70 mungkin, isteri ada lagi anak 6 orang, ada kecil manis lama dah, dan dia start ada kerosakan buah pinggang. So dia dah ada kerosakan buah pinggang mungkin 5 years ago, tapi tak sampai ke peringkat dialysis. So at that point, 5 years ago, people start to have conversation. Do you think dialysis is something you want to do? So 70-year-old, if you tanya rata-rata Malaysian lah, 70-year-old, okay, 5 years ago, 65, you've had conversation, do you want dialysis or not? Most people will say yes, but when you reach 70, people will say, nak dialysis ke tak? Orang kata, tak sure lah. Kan? But, so then again, if we know this person value, so say, kata kalau pakcik ni umur 70 dah, his daily activity is going to the masjid, which is very important to him. Okay, 5 waktu dia boleh pergi ke masjid. He's strong, boleh berjalan, everything semua. And that is very important. Anak dia dah kata-kata, 6 orang dah kata, cucu pun ramai apa semua, but he's independent, wife dia pun independent. And his value is, I have to go to masjid. This is very important to me. So, if you talk to any nephrologist, this person wants to do dialysis. Dia belak-belak, 5 years ago nak buat dialysis. Belak-belak, important for this person is actually going to the masjid. So, maybe hemodialysis, kena hangkut pergi ke tempat dialysis 3 kali seminggu tu akan kacau dia nak pergi solat ni. So maybe we can change it to a CAPD, continuous dialysis di rumah tu, yang dibuat kat rumah, dia buat 4 kali sehari, tapi dia boleh pergi masjid semayang. Dia buat sebab it's 4 times a day, the exchange takes about 1 hour only. So kalau you ada this discussion, this advanced care planning, nobody will question, 70 nak dialysis ke? Yes, I want the perut punya dialysis air tu, because I can go to masjid and continue my prayer, which is important to me. So that's why when you have advanced care planning, people understand who you are, and people can adjust the treatment to who you are. Okay, so I give another. Usually ACP ni, we dua benda yang kita orang akan sentuh, which is quite important, is actually about CPR and intubation. So CPR ni cardiopulmonary resuscitation, which is kalau drama swasta tu yang tekan dada tu kan, nak hidupkan orang balik kan. Actually, success rate of that is actually about 5 to 10% sahaja. And 5 and 10% alive, bukan 5 and 10% well. So those people who actually come out well is actually lower. So jadinya, if you have no illness and you had an ACP done, if I suddenly become unwell, I do not want to be bedbound connecting to tubes where I might be alive, but I have no control over myself. Dia macam vegetative state, maknanya dia macam orang sedar, boleh buka mata tapi bercakap tak boleh, kencing semua kena pakai tube, makan pun pakai tube,
Kita kata no quality of life lah kan. Walaupun you're alive, you don't have the
Yeah.
quality of life anymore lah.
That comes again, Sani, bergantung juga sebabnya. So if you kata this is not something you want, tapi you sihat, tak ada penyakit apa-apa, then suddenly you kena accident and your heart stop and you had a CPR done, and then katakan you dah married, everything semua muda lagi 30 plus, you sampai hospital, they were able to bring you back to life. You're alive with the assistance dengan machine apa semua. Okay, reasonable. They cut down, you breathing on room and everything, but you're stuck, brain damage, you're lying there, and your wife pernah ada this conversation with you that if I become like this is not the life I want. So it's actually okay to approach the healthcare professional. My husband had this discussion with me before, ideally documented lah kan, tapi nak buat macam mana, we're going towards that. So if you talk to your healthcare worker, this is not my value to be vegetated like this, to be supported like this. You can talk to your doctor maksudnya, when we may withdraw treatment, kita tak bunuh dia, kita taklah bagi ubat menyebabkan dia meninggal, no. We withdraw treatment and we let nature run its course. Because if we go back 160 years ago, if somebody kena langgar katlau lah 160 years ago, ada kereta kan, kena langgar and you had brain injury, chances are you're gonna die. But now with advance of technology, you are still alive, but is this the value of living that you want? So when you have an ACP, you let your family members know and everything, they boleh tahu, oh, this is not what I want. I bagi tahu you Sani, because not everybody thinks it's not quality of life. I had a 92-year-old gentleman, can't remember dia ada cancer ke tak, tapi he's quite unwell. I think dia tak ada cancer, tapi dia ada a lot of medical illness, kidney, everything semua. He wanted to be kept alive artificially juga, sebabnya dia ada seorang anak yang mana his value of living is as long as he's alive, anak dia akan continue working. Anak dia ni successful businessman, berkaya raya lah. So dia mampu lah untuk ventilation, everything semua tu dia mampu. So we sat down and we discussed with this anak, but everybody said he's 90, what are you doing? It's pain for him. But we sat down and talked to the son. The son said, actually, I'm working because my father is still alive and he knows that, and he told us that to keep him alive regardless, because he want me to continue to be successful. So for that man, walaupun dah intubated masa tu, I don't know whether he survived for 1 month lah dekat ventilated dekat general ward, bukan kat ICU tau, ventilated dekat general ward. Survive 1 month. We had to talk to the primary team and everything semua tu. This is the value of this person. Kita take into consideration resources jugalah, resources, everything. And dia survive lah for when I left, he was still alive. I don't know whether he's still alive after that or not. But 1 month in the ICU and kept him alive on minimal life-sustaining treatment. Sebab resources kita kena be fair. And he was kept alive because that was his value. He wanted to be kept alive regardless. And this conversation happened, this 92-year-old, he had a conversation long ago with the children lah. And they are aware what the father wishes were. And even though it hurts them, they kind of don't agree for themselves or their families. Tapi this old 92-year-old, dia kata, do this to me. Dia punya value dia, as long as he's alive, the children will be well. That was his value. So we understood that, we worked with it, negotiate and everything. So, I mean, he had an advanced care planning done, and our role is actually to assist with that. So that is understanding the person value is part of advanced care planning, to understand what is your value, and your value changes. Okay, I have 7 children, so my value when I had no children and my value when I have 7 is completely different. So that's why advanced care planning is not a document you tulis je and set in stone. No, it's a conversation with your loved one, your family, and ideally your healthcare workers, so that they understand your value and where you are. So another component of ACP is actually a decision maker if you're not able to make decision. So that's also important. So macam orang assume kalau you dah kahwin, bini buat keputusan lah. Okay, 21 years married and I know my wife kind of knows me, but she really doesn't understand what my wants are. Different. So jadi you can ideally in our Asian society, our Asian culture, kita akan letakkan keputusan untuk buat keputusan tu adalah ke atas isteri. But certain culture, certain families kita tahu yang buat keputusan sebenarnya pak mertua, yang buat keputusan sebenarnya ayah kita kalau dia orang still around lah, ataupun adik-beradik, abang long yang buat keputusan sebenarnya. So who makes a decision about your health choices if you're not able to. Kalau kita sendiri sialah macam head injury, tak boleh nak sedar apa semua tu, then you can't make a decision. Ataupun yang common dekat Malaysia sekarang, taklah common sangat tapi getting more common, is actually dementia. Kita dah jadi makin nyanyuk. So kalau kita dah jadi makin nyanyuk, in your 60s, you're starting noticing alamak ada problem, ingatan tak ingat, then your 65 getting a bit more worse. It's a good idea having a conversation with your family who's going to make a decision for you. Healthcare decision. Berkongsi cerita. I had a 73 kot. Pakcik ni has cancer. He doesn't want to know that he has cancer. Tetapi dia dah buat pembedahan, dia dah buat chemo. Kenapa? Sebab dia dah make a decision. My illness, decision maker is going to be my son. So dia kata, apa-apa masalah, dia salahkan anak dia. So he make a decision. Dia farmer, orang not that well educated, sekolah rendah pun, maybe sekolah rendah saja. He knows his ability, so dia tahu dia tak akan faham doktor tengah apa-apa. So dia nak keputusan pasal my health is my son's decision, to make that decision. So he follow je lah whatever son dia buat decision. Because the son understand the conversation with doctor more. So dia buatlah surgery, everything, buat berdapur, everything semua tu. Because when I met this pakcik, I was like, pakcik, ya ke nak buat benda ni? Oh doktor, saya tak nak tahu pasal penyakit saya. Semuanya bagi tahu kan anak lelaki saya, dia buat keputusan, saya ikut. And he had a laparotomy, dia buat pembedahan perut, buang usus apa semua. I'm like, wow pakcik, percayanya dekat anaknya. Because who went through, yes, he went through a big surgery based on his trust to his child. Again, it's about value, and when you identify that person to make decision for you, okay, you trust lah that person. For me, it will be my wife lah. Tapi for other people, if you have a wife, fair. Kalau you ada husband, fair. Kalau it is culturally kita expect. But if you go through, talk to the families, ramai je partner ni sebenarnya, katakanlah suami yang cedera, isteri nak buat keputusan, dah dia kena consider ipar-ipar dia tu. Apa kalau mak mertua tu ada dia buat decision, alamak boleh ke tak. It's actually a big stressor to the spouse to make a decision, unless you as the person declare to everybody, whatever happens to me, my wife's gonna make a decision. You follow her decision. You jangan sangkal. Walaupun you prof apa-apa ke, yang ni housewife ke, she makes a decision for me. So yelah kan, sebab kita, kalau lah isteri tu housewife, mungkin dapat degree tapi dia tak ada bigger housewife. Ni lawan dengan prof-prof, adik-beradik semua prof-prof semua, kau nak kata apa? So understanding that also helps in making a clinical decision about your healthcare plan lah.
So macam advanced care planning ni, actually dekat Malaysia, I understand dia belum lagi kita kata macam roll out lah officially lah. Tapi what Dr. Ammar was talking about just now, mungkin I think advanced care planning ni dah berleluasa sebenarnya. Mungkin secara informal, mungkin orang tak sedar pun ni adalah advanced care planning yang kadang-kadang we have conversation, kita sembang dengan wife kita, kata wife kita mungkin satu hari kalau kita jadi sekian, kita nak macam ni. I think that is considered an advanced care planning lah, walaupun it's not documented anywhere. Cuma dekat Malaysia ni, because kita tak ada satu healthcare provider yang jaga sekelompok family, mungkin macam kat UK dan sebagainya. So oftentimes kita akan berdepan dengan different healthcare facilities and also personnel. So macam mana those personnel yang kita jumpa always bertukar-tukar doktor dan sebagainya will, how to say, know legally ataupun non-legally whether this decision yang wife dia ni buat ni, is it betul ke dia ni? Do you have any evidence ke proof ke? Because what I understand, especially dalam culture kita ni, like Dr. Ammar said, benda ni very very stress kepada orang yang nak kena make decision, because I think the family dia nak kena fikir apa kata family dia yang lain kan. Kalau let's say jadi kat laki dia yang accident, dia nak kena consider what are the other family members punya perasaan. Maybe ada some of them yang on the other side yang macam alpha, dia nak buat decision kan, walaupun yelah mungkin decision tu dah dibincangkan bersama suami dia supaya decision life or death ni dibuat oleh isteri dia. So in that kind of scenario, siapa yang lebih layak buat decision tu?
Okay, so again, the decision maker is always you, Kaki kita lah, tubuh kita. Allah bagi amanah kat kita kena jaga kan. So decision maker is always you. So what we have identified lacking in current society now is actually lack of communication. So we may be communicating with our wife tapi kita tak communicate dengan adik-beradik. So jadinya adik-beradik tak tahu kita actually dah communicate dengan wife kita. So and yes, you're right. Kalau dekat UK, Ireland, you can actually talk to your GP. Your GP will document this, and it kind of becomes a basis lah. So what we've been trying to do nowadays, orang yang sihat ni susah sikit lah. That's why there's a movement untuk making this a bit more aware, so people have a conversation, but people are aware about this. Kalau budak 16 tahun, 17 tahun, people assume is mak ayah dia akan buat decision sebab kita kata by legally dia tahu kan. But 16-year-old dekat Malaysia, Aryan dah kahwin, Aryan dah ada suami. So is it going to be the parents, is it going to be the husband? Kan? So for young people, for people who know illness, everything, just have a conversation, talk to your loved one, talk to your family, and make them aware what's your ideas and what your values are, what is important to you, and who's going to make decision for you. People yang berpenyakit, what we are trying to encourage the doctors, the healthcare worker now is actually to document it in your documentation masa kita datang. Okay, one of the documentation, who's going to be the surrogate decision maker? Pak letak sekali. So maybe I saw this person ada darah tinggi je kot. Pakcik nak tanya je pakcik. Kod lah jadi apa ke pakcik? Siapa nak urusan kau je kalau pakcik kena cakap pagi bisu lepas ni? Siapa nak urusan? Okay, sekarang ni bini saya. 5 years down the line dia ada hypertension and diabetes. Somebody might just can I you wrote before this your wife to make decision. Boleh tak nak tanya? Sekarang ni rasanya memang istilah juga nak buat kalau pakcik tak ada cakap. Sekarang ni saya nak tukar anak saya. You can always change it. It's not set in stone, but having that conversation is important. So healthcare workers going to be trained to be more aware to ask this question. When you see a patient, janganlah every single time dah tengok documented sebulan lepas tak payahlah kata-kata tanya. So maybe 5 years ago ke 3 years ago ke, just ask, okay, is this still valid? Is this something you still want to keep? Macam tu. But you never know. Oh yeah, that's my first wife. Now I have 3 wives. I want my third wife to make decision pula dah. So
masalah besar tu.
So when we have worker document this, it kind of becomes an evidence. Kalau tiba-tiba pak saudara dia nak make a decision, minta maaf ya encik, dia dah jelas mengatakan kalau jadi apa-apa kat dia, bini nombor 3 dia yang akan buat keputusan. So pak saudara dia, aku ni profesor apa? Ya, bagus prof. Tapi sorry dia dah bagi tahu. This is his living will. This is what he wants. So that's why
on the ground kan Dr. Ammar kan, actually on the ground bila kita tengok especially dekat emergency room lah kan, orang yang nak buat decision tu selalunya tak ada kat situ. So what happens is the healthcare personnel akan buat the decision for them kan. Kalau intubate kita intubate, kalau CPR kita CPR sampailah orang yang boleh buat decision tu datang. Dia kata stop, kita stop lah. That is what we always do lah kalau practice dekat Malaysia ni. Cuma itulah bila kita, I think the downside is bila kita letak someone untuk decide, family lain ada kan, cuma dia nak tunggu juga orang yang nak buat decision tu datang untuk tengok dan lihat, which we do not know whether it will be 20 maybe 30 minutes. Patient dah tengah CPR dah prap semua tulang rusuk dah kan. So that is, I think that is one of the downside lah bila kita bagi only one person can make the decision. Boleh tak kalau 2-3 orang yang diberi amanah ni?
Yes, boleh. So I have a lot of my patients yang bagi tahu who's going to be a surrogate decision maker is going to be a discussion between my children. So yes. So it's it can be like that. So it's senang if it's 1 or 2 person. You boleh letak number 1 ni, tak boleh number 2, tak boleh number 1, number 2 yang buat decision. You boleh letak macam tu. Because we don't know what's going to happen in the future. We don't know what's going to happen to us. And it has happened juga. Patient become unresponsive. Decision maker number 1 and number 2 understand patient punya value. Dia kata no, dia nak. But for some reason, patient become aware and he went through this. This is a kidney failure patient. Dia jadi lemas because of fluid overload. Air banyak kan. Dia jadi lemas. And he went to the extent of what is fluid overload. He said, I want dialysis now. Fix me. Because dia yang merasainya. So he changed that, which is completely okay. But from the healthcare professional point of view, you do what you're trained to do. So I used to work in hospital Kepala Batas before. I was a medical physician over there. Kebetulan jugalah a patient yang end-stage renal failure I kenal kebetulan, tapi my junior doktor yang tengok dulu, dan dia naik dah ke ward, dan dia junior doktor selama, yelah, she didn't know, dia tengok pesakit ni betul lah critical, dia nak intubate and everything. I said okay lah, I tengah round acute, dia patient tu masuk subacute sebab memang there was a bit of discussion dia tak nak aktif bla 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 semua tu, tapi she felt that this cannot lah, the bicarb below the acetosis dose is too high, have to intubate, have to save his life. Dia pun lalu je kat bos, I nak intubate orang ni, bicarb ini, okay, I kata. So, but kebetulan I dah nak intubate, I dah habis round the acute, I pergilah tengok, nak intubate ni, kita tengoklah set. Tengok, pakcik, don't intubate this one, I know. So, I start my medication to alleviate his breathlessness. He regained consciousness when his last kidney. He regained consciousness. Boleh kat tangan, say hi, me. But then again, we call the children because I know that man, because I've seen in my clinic before, I know this man, he's valued, dia sebenarnya quite muda, government servant, boleh buat dari sisi issue sebenarnya, tetapi he chose not to because he looked after his mother who went through dialysis, he looked after his brother who went through dialysis, and he doesn't want to go through the same pain. Dia nampak benda tu suffering. So he doesn't want to go through the same pain. And he talked to his children. So the children is aware, cuma dia breathless kat rumah, dia orang tak tahu nak buat apa. So we did give a bit of medication, tapi family tak tahu nak guna sangat morphine kot masa tu. But anyway, came to hospital because breathless. Junior doctor saw have to help this breathless. He said, betul, I agree. Kalau you intubate this person, you dialysis, he's going to be well. But the value is not what he wants. So talk to the family, reaffirm balik, bagi tahu anak dia, anak tu mengaku kita tahu ayah tak nak dialysis, ayah dah jelas memang tak nak. So I initiate the fentanyl leveling semua tu. He was, boleh angkat tangan, had moments with his children. I think I saw him about 9:30 pagi. By 12 tu he passed away already. As a Muslim, saya nak tambah sikit lah. As a Muslim, kadang-kadang like I said it. I think if we intubate this person with dialysis, he might be well again, okay? That's based on my medical knowledge, based on his blood parameters and everything. I felt that if we do that, he might be well. But his value is clear, he doesn't want all that, and I follow that. And then he passed away pukul 12 tengah hari macam tu, 3 hours, he got to spend time with his family. As a Muslim, kullu nafsin za'iqatul maut kan? So, I intervene ke, I tak intervene ke, he might have died when I wanted to initiate dialysis, intubated, not, being with his family. So I feel very relieved being a palliative person that being Muslim, I don't control death. God control death. So I try to alleviate and do what is important and necessary within medical reason for this person. To that, I can appreciate his value. Boleh dapat yang betul dia nak. And the family was very satisfied. Bapak dia tak sengsara lah. Yelah, mengah kat rumah malam tadi dah, tapi dekat hospital quite calm, quite relaxed, and they get to spend time with him. They say goodbye and everything, which is important jugalah. Sebab memang Allah nak umur dia waktu tu, so at least they were able to be there with the family. So that's why having this conversation, understanding siapa decision maker, understanding what your value, and talk to your family so that they can actually give the information to healthcare worker, so that kita boleh capai apa yang kita nak. The good thing about medicine is actually as you practice more, you see more people, you get more experience. See, I have to admit this is one of the things about being a doctor is that you see more death. And when you see more death, people change the value. That's why, yelah, kita dah tengok kematian tu macam mana. And us healthcare worker, doctor, nurses yang kerja kat hospital ni, we see so many types of death. So banyak jenis berlaku. And I can, being in my field, palliative care, I know people tak biasa menguruskan kematian di rumah. So people get scared of what to do. I kena ada mesin macam-macam because Hollywood has showed when you're dying, there's a lot of machines around you. So actually what happens 160 years ago, people die at home because that's what's natural. And to learn back the whole process, how to do it comfortable, how to do it dignified at home, we have to relearn it and reteach it back. And our generation, our parents meninggal di rumah is tak biasa. So we have to relearn, reinforce balik this is actually okay, how to handle it. But we have medication lah that makes things a bit better lah, yes. But death is a natural thing that will occur to everyone. It's just how you prepare for it is what makes a difference now. So that's why palliative care is always associated with death, because we are always there when somebody is dying, because we to support them along the journey too. But we don't actually kata, yes, don't do anything to everybody. No, do things as appropriate, because that's why we're medical specialists juga. It's a specialty lah. We have to go tiba-tiba je. I give an example. Somebody 18-year-old dah legal age requirement. Oh, I tak nak CPR. But kalau you kena langgar kereta, I will CPR you first. I will overrule your decision. And if you end up patah kaki sahaja and you're cognitively well afterwards, well, good for you. Tapi kalau I follow your instruction, because I'm a medical person, I have my ethics and my value yang I kena practice juga lah. So if this young 18-year-old kena langgar, then dia kata tak nak CPR, no, I will fix your legs and everything semua, you up and about and running, okay, and then you nak sue me because I treated you. Well, let's discuss about that later on. Dekat Malaysia tak pernah dicabar lagi dari segi undang-undang. Dekat US, dekat luar, benda tu pernah dicabar. But generally as a medical profession, most people will treat lah, because there are some from the cases from previously, orang marah doktor rawat elok, lepas tu dia masalah kalau doktor sebab rawat dia. It has happened in the West lah. But when you look, actually there's a lot of communication error, there's a lot of underlying illness yang tak pernah settle apa semua tu, there's a lot of things that's not been settled lah. So
Itulah nak tanya doktor, kalau you take the decision dari segi ethics and also isu saman menyaman ni lah kan, I think dekat Malaysia memang mungkin jarang ataupun tak pernah berlaku lagi lah. Cuma when you make the decision untuk tidak intubate patient, intubate ni untuk yang tak tahu, kita masukkan satu tube ke saluran pernafasan untuk bantu pesakit lebih mudah bernafas lah, kita take over pernafasan pesakit. When we make the decision not to intubate for a certain patient, is there any legal ataupun litigation risk from the family members? Mungkin after that, when the patient dies, contoh tadi, patient tadi meninggal at 12, mungkin some of the family members may say, why did you not do more for my father? Kan, you could have intubate, you could have this, you could have that, why did you not do that? So is there anything to back us up as a medical personnel lah?
Yes. So you work with what you have, what your capability are. So macam okay, kalau you dah assess this patient, you think needs intubation, tapi value dia tak kena, value dia kata he doesn't want intubation. So go with what is documented for that patient, and you do as per that discussion with that patient. So ideally ada benda cantik-cantik documented before lah. Tapi kalau you tak ada, you seorang je dengar dan patient backup 6 kata, oh I tak nak intubate. If you argue it, nobody, no nephrologist or anesthetist will say backup 6 make a conscious decision. People can argue he's not making a conscious decision. So what you do is actually you saw the values, you tengok dia punya parameters dia, you rasa this unwell person, you go ahead and do it. So say lah kalau person ni dah conversation, dah ada documentation, dia kata tak nak benda ni, intubation apa semua tak nak, you tengok ni teruk sangat to intubate, but dia dah document tak nak, and then you risau family dia sebab doktor typical lah, doktor buatlah yang terbaik untuk ayah saya. What's terbaik now?
So that's why you become in the middle.
Yeah.
You nak dengar cakap family ke, you nak dengar cakap patient yang dah pernah document. So the question is whether the family members overrule at that time, at that moment, whether the family punya decision as a whole overrule the patient's punya decision.
Okay, so it goes back to your documentation, your setting lah. So kalau in a hospital yang documentation accessible, senang dapat tengok, that's why electronic documentation notes is very very nice, but you can go through it. It's been documented here. You can actually go and stand with what was documented in the document, because it's a legally binding document. So you're doing nothing wrong if you're respecting the patient's wishes. The family members and everything semua tu boleh sue back. It has happened in Malaysia. I can tell you that. It has happened in feedback, but they have no ground to stand on when it's documented. Yang masalahnya kalau tak documented, you dengar time dia tengah ngak-ngak tu kan, backup 6, dia kata dia nak intubate, kata tolonglah selamatkan ayah saya. Tapi it wasn't documented anywhere, no conversation anywhere, nothing, tak tahu, but you decided not to intubate because pakcik kata macam tu. What you can do at that point is actually call in your bosses. There is no other better time to call in your bosses pukul 2 pagi ke 3 pagi ke, and you discuss je with your bosses, choose your superior. Even I might be a palliative physician in training at the moment, tapi I still have my boss. So if I have difficult, I call up my boss, not to shift responsibility, untuk get a more experienced person opinion. And I can tell you, most of the time when patient saman balik sebab ni semua, most of the time it's actually poor communication, attitude, behavior, doctors, nurses, and everything towards the family. Most of the time that is the big thing. Dia bengkak dengan cara misi tu cakap ke, bengkak dengan doktor ni sombong sangat. That's why dia sakit hati tu, and the father passed away, yes. And they find a reason to blame, which is quite common. If you go to the western side, eastern side, sama je. The usual reason is actually because there's a breakdown in communication in between.
So, I think banyak dah kita go through dalam podcast hari ni. Kita go through a lot of things about cancer, ACP, benda-benda very important things that is a bit a hard conversation lah untuk kita bincang dengan spouse ataupun family members kita. Tapi I feel that perbincangan apa akan berlaku dekat kita apabila kita tak dapat membuat keputusan waktu tu. I think that is a very important topic. Mau ke tak mau, kita as adults, kita have to have this difficult conversation lah. And insyaAllah mungkin orang yang tak tahu, Dr. Ammar ni juga adalah seorang professional bodybuilder. That's why, but regardless of his status as a bodybuilder, I think I totally agree lah dengan your statement regarding the muscle mass, because kita tahu those patients above 60, 65, the major risk factor ataupun the major cause of death is actually following a fall. Once they fall, they break a hip, they become bedbound, and that's when everything goes to where lah kan. So I think building muscle is a good way to mitigate all those risk factor. So saya harap all those yang listening start to do your medical checkup, start to do your screenings, and we have a lot of screenings that maybe we can go on about it in another podcast. For example, breast, kita ada a specific way to screen for breast cancer. Colon cancer, we have a specific way untuk kita screen colon cancer, and bukan semua kita screen menggunakan ujian darah, tumor markers tu. Ada role, tapi if it's abnormal, doesn't necessarily mean that you have cancer yet. So I think that's about it for this podcast. So I want to thank Dr. Ammar sangat-sangat untuk memberi kita kata knowledge lah yang kita kata susah nak dapat ni, nak sembang dengan doktor pakar dekat klinik sejam lebih macam ni memang tak dapat lah. So I think it's a very good opportunity lah. InsyaAllah Dr. Ammar boleh join kita lagi dalam podcast yang seterusnya.